Welcome on in and thanks for joining us for Healthline 3. I'm Jamie Ostroff, and today we are talking with Dr. Ashley Baker of Regional Urology about the subject of urinary tract infections and urge incontinence. We will be talking for the next half hour, and of course we want to encourage you to ask us what's on your mind. If you are online, just click on the Healthline 3 box. It's halfway down the right side of your screen. You can type in your question and submit it, or do it the old-fashioned way. Just give us a call. The number on your screen, 318-219-4569. We will be taking questions until 12:30. Dr. Baker, thank you so much for joining us.
Thanks for having me.
All right, so we are here to talk about urinary tract infections and urge incontinence. Tell me a little bit about those issues.
Yeah, so two separate urologic issues that we see a pretty significant number of in our clinic. As you said, I work over at Regional Urology, and I have a number of partners, so I'm able to sort of subspecialize in issues. And two of those things that I take care of often are urinary tract infection and urgency incontinence. Urinary tract infection runs the gamut from bladder infection to kidney infection, and urgency incontinence is leakage of urine that is unrelated to a prompt, such as a cough or a sneeze. So sudden urge to urinate, can't control it, and then have an episode of leakage.
All right, and we already have a caller. Cheryl, thank you so much for reaching out. What is your question?
I'm a diabetic, and I just about a month ago started a new medication that causes dehydration. I had to go to the emergency room, and didn't have follow-up with the urologist like they said, but they diagnosed me with a condition called dysuria, I believe it's called.
Probably glucoseuria, does that sound right?
What is it?
Glucoseuria, glucose in the urine?
It was just a general dysuria, from what I understand.
Okay.
I didn't get a lot of information.
Okay.
And there's no infection. My liver enzymes, kidney enzymes were all perfect, but I didn't get a lot of information. There was no infection or anything, you know. And I'm a caffeine addict. Tea, coffee, and all that. No, not a lot of water. And I just wanted to know about how long do I expect this to last? I know I need to, push fluid, but what's the general consensus of this disorder?
Yeah, well, certainly diabetics are more prone to having a higher urine volume than somebody who's not a diabetic. A lot of the newer bladder medications actually are designed to eliminate some of the extra sugar that your body can't handle on its own through the urine. And so we do see diabetics have a higher risk of having dehydration or having trouble with their urinary tract related to a combination of both the diabetes and then also the way that we manage that medically speaking too. So as good of diabetic control as you can have obviously limits the amount of sugar that you're spilling outwardly into the urine, though that's complicated too because some of the medications are actually designed to treat diabetes by lowering blood sugar, by eliminating it out through the urine as well. So it's a little bit circular in logic, but good hydration, watching your blood sugar, those are the keys to try and eliminate the infectious aspect related to diabetes.
Right. Well, I was wondering too, is some of the medications like the azos and stuff like that, would that help with this disorder?
Sure, yeah, it certainly is good for short-term use. A lot of those medications, the instructions for taking them will say that if you're requiring them for more than a few days, that you need to talk about it with your primary care physician or your urologist to kind of help delve into that a little bit further. But yes, those are safe to buy over the counter and use, especially in the short term.
Okay, thank you.
Yeah, sure.
Thanks, Cheryl. And if you want to give out your number right now for anybody who wants to give your office a call and consult you, I'll ask you a bunch of times.
Okay, perfect. So our phone number at Regional Urology is 318-683-0411.
All right. And meanwhile, when we were talking earlier, you mentioned urinary tract infections were kind of an all-encompassing term for a number of things that could go wrong. who do they infect, or who do they affect the most?
Yeah, so it actually varies pretty widely. There certainly are at-risk populations, and so there are children, babies, that are born with anatomical issues that they were born with, so abnormalities in the way that their kidneys were formed when they were in utero that predispose them to being at risk for infection. So we see a good bit of that. Certainly women who are going through hormonal changes are prone to having bladder infections or kidney infections, and so we see a number of women that are in that postmenopausal age group or perimenopausal age group. Men are predisposed to prostate infections, and so we also see men who are struggling with prostate infections, and that can vary all ages of men. So really it covers pretty widely in terms of gender and age. We see a number of patients with those problems.
And UTI is very easy to treat.
Yeah, most of the time it is. Most of the time what we call a simple urinary tract infection is pretty easily treated with, we used to say antibiotics, but we've learned now that you don't always necessarily have to have antibiotics to treat bladder infections, for instance. There are things that we can do behaviorally and things that we can do with our diet and our lifestyle to help minimize the symptoms that we experience related to that. A lot of the times if it's more than just a sort of low-level bladder infection, it does require antibiotics, but most of the time it can be treated within 3 to 7 days of medication.
What are some of those diet and behavioral changes?
Yeah, as much water as we can stand to drink, the better. Caffeine increases risk of urinary tract infections, and so limiting caffeine. I say that a little bit tongue-in-cheek because I admittedly love caffeine. So,
sure.
But yes, as much water as can help. Limiting sugar, a healthy, just well-rounded diet, really. Yeah.
All right, and our last caller also mentioned some of the over-the-counter treatments. Those are legit too.
Yeah, some of them certainly are. I always caution patients to be careful with some of the things that they use if they're using it chronically, because a lot of those things aren't necessarily regulated by the FDA. However, there are a number of things that are good for symptom control for the symptoms that are related to a urinary tract infection. So some of those symptoms may be burning with urination, pain in the lower part of the abdomen, sort of a spasm feeling. But obviously if you're experiencing fever, or if you experience pain up in the flank or something along those lines, those are signs that your infection potentially is progressing to a level that would require more aggressive antibiotic therapy and evaluation by your physician.
Yeah, what can happen if you let something like that go too long before you treat it?
Yeah, so worst case, the urinary tract is nice and contained for the most part, and by that I mean that our kidneys form urine and excrete the urine down the ureters down into the bladder. Most people's bladder infections or kidney infections will remain confined to symptoms related in the bladder. The worst case is that it progresses, it's not treated adequately with antibiotics, and the infection crosses out of that barrier and gets into the bloodstream. And then you're into the category of what we call sepsis, which means bacteria is growing in the bloodstream. And that can be life-threatening.
So intervene early, as early as possible.
Sure.
What are some of those first signs and symptoms so that a person knows?
Sure. So a lot of patients tell me that their earliest symptoms are urgency. So they'll feel the desire to use the restroom, and instead of being able to kind of say, okay, well, I'm on the air right now, I can't use the restroom, for instance, that it's more urgent. They don't have time to delay that. They notice that they really feel increasing discomfort as they delay that. And so some patients will tell me that that's one of the earlier signs. Foul odor to the urine is a common complaint. Burning with urination, feeling discomfort or burning with urination are probably 3 of the earliest signs that people experience.
All right, and we have another caller now. John, thanks for calling. John, are you with us? All right, okay. we lost John, but we can continue this conversation. Again, the number is there at the bottom of your screen, 219-4569. I'm squinting a little bit, but I believe that is the number. I hope you can see it too. What is the biggest misconception I think that people have about UTIs?
I think as probably that it's their fault. We historically, I think physicians have done a little bit of a poor job in talking to their patients about urinary tract infections or bladder infections. So while certainly there are things that we can do that increase our risk of urinary tract infections, for the most part, patients really are doing their very best and doing all the right things to try to prevent it. For instance, we would tell patients that it could be related to poor hygiene, or it could be related to the type of soap that you're bathing with. It could be related to detergents that you're washing clothes with. It could be related to particular habits. And while that's partially true, we also have learned in the last really 5 years that there's actually a genetic predisposition for urinary tract infections. So sometimes people are genetically prone to it, and it's out of their control.
All right, and we do have another caller now. Barbara, thank you for calling.
Thank you.
What's your question?
I wanted to thank Dr. Baker. I'm a patient of hers. For a postmenopausal woman that is a cancer survivor, there's not many options for incontinence or problems with the urinary tract. And the InterStim is a lifesaver.
No.
And I want to thank her and give a shout out to the women that's having this problem. There is a way, or there's medication, and steps that you can take that will keep you from having this problem, that will change your life and give you the freedom. Thank you, Dr. Baker.
Oh, thank you. Thank you. What she's referring to is a therapy that we do called InterStim. It's for patients that have severe overactive bladder and urgency incontinence. And this ties in closely with urinary tract infection, because a lot of the times we'll see women who have both of those conditions. They tend to kind of cluster together. And InterStim is a therapy for overactive bladder and urgency incontinence, and also bowel incontinence. That is essentially a little small pacemaker for the bladder. And so that's what she was referring to with InterStim, but thank you.
How does that work?
Yeah, it's really interesting. It's sacral neuromodulation is really what it is. And what that is there is a little lead that we place in a procedure using X-ray, and it's down in the area of the tailbone, down in the sacral openings of the tailbone. The nerve that runs to the bladder and to the rectum runs just under that tailbone. And basically the little lead that we place provides slight stimulation to the nerve to train the bladder to be a better storage vessel of urine, and to train the rectum to be a better storage vessel of stool. And so it is certainly life-changing for some people who have very profound incontinence. And I do that procedure often and consider it a privilege to get to do that. I mean, it really, it's nice to see the outcomes in all aspects, including helping people get through bladder infections, get through urinary incontinence, get through bowel incontinence. These are private things, and patients don't love talking to their physicians about it, and I don't blame them. I totally understand that. But the important message is that there are things we can do for it. Yeah.
You said you perform the procedure yourself. How invasive is it, and what does it require of a patient?
Sure, it's fairly minimally invasive. We do it in an operating room area, mainly so that we're in a sterile environment, because we're actually putting a small implant into the patient. It involves sedation, just similar, not even really as severe as if you were having a colonoscopy, but it involves sedation. It involves a little bit of local anesthesia. I communicate with the patient, and we do some testing to confirm that we have it in the appropriate location. And then we have nursing staff, and I help as well sort of work with the patient in the postoperative period to get it on the optimal settings. And then it's pretty low maintenance. It's all contained under the skin. It has a battery, actually, similar to a pacemaker battery. The lifespan of that battery is anywhere between 5 and 8 years. And so it is something for the patient to undergo, obviously, and it is procedural, but I would not consider it a major operation.
And they have to get it kind of refreshed every 5 to 8 years as the battery runs out?
Yeah, correct. You may end up having to change the battery depending. And some people, if we can get it to where it's running on very low settings for them, they don't necessarily have to change the battery that often, but that's about the average.
And this is something that can be adjusted?
Correct, yeah.
Wow, so this is this very modern way of handling incontinence. Tell me a little bit more generally about what you see in patients who are experiencing urge incontinence.
Sure, yes. So urgency incontinence is far more common in women, though we do see it in men as well. We do certainly see men who have urgency incontinence, and it tends to onset in most people. It tends to onset in sort of midlife age range, though there also are children that have it and experience it lifelong. So a small subset of people will see it much younger than that. Typically, what they report is the inability to control their bladder. And basically what's happening is, for some reason, the complex control of the bladder, which takes place in our brain and our spinal cord and down in our pelvic nerves, somewhere the communication is off. And what it results in is patients' bladders emptying without them telling their bladder to empty, or without them being in a place such as a restroom or wherever where they are trying to eliminate urine. We often can manage that. We start with behavioral modifications and with lifestyle modifications. So medications are not really in the picture first line, but we talk about limiting caffeine. We talk about adequate hydration. We talk about going to the bathroom on a schedule so that you're not waiting until your bladder is maximally full. About 30% of patients with overactive bladder can probably control it well enough in that capacity. Others, no matter what they do from a behavioral and a lifestyle standpoint, still progress and still have incontinence. And so then we get into the medications for overactive bladder. There's a number of those. When patients fail medications, we tend to do further testing to try to determine why they leak urine or why they leak bowel material. And then ultimately there are therapies beyond medications, such as InterStim, Botox injections into the bladder. Yes.
We're going to get back to that in a minute.
And then there's something called posterior tibial nerve stimulation, which is another procedural therapy that we do in the office. So a lot of things have been approved and are available to patients to treat those problems, even beyond the medications.
And there are a lot of things that could cause incontinence.
Yeah, absolutely.
Tell me about some of those causes.
Sure. So a lot of neurologic disorders can cause incontinence. So we will see young men or women who have multiple sclerosis. We will see people with Parkinson's disease, with dementias. Diabetes can predispose to incontinence. Certain pelvic surgeries or damage to the nerves in the pelvis. Pelvic traumas can cause urinary leakage. And then some people, you're genetically predisposed to urinary leakage, and we don't really have any great explanation for why that is. So they don't meet any of those other criteria, but they still have problems with overactive bladder and incontinence.
And I think you might have mentioned it, childbirth.
Yeah.
I know that's a very common one.
Sure, it is. Yeah, certainly vaginal deliveries, and even after cesarean, having a baby, the way that the majority of babies engage down in the pelvis in a woman, for a lot of their second trimester, they have a head down into their pelvis and putting pressure down on pelvic musculature, and certainly that can affect continence as well. Yeah.
All right, we have Eileen on the line now. Eileen, what is your question?
Yes, I was wondering, how long does the UTIs last, and how long do they keep coming back?
Yeah. Thanks, Eileen. That's a tough one to answer, honestly. While certainly there are patients that have an isolated urinary tract infection or kidney infection, bladder infection, and then it clears within a few days, within a week. There are others that have persistence of bladder infections and really have a lot of trouble getting those cleared. And so when you get into the recurrent category, where let's say you have more than 3 or 4 infections in a 1-year period or in a 6-month period, we do...
Yeah,
I'm sorry, go ahead.
I do.
Yes, and so for those patients, especially if there are other medical illnesses that put you at risk for having complications related to it, most physicians would recommend that you undergo a workup to try and figure out why you're having issues with recurrent infection and why it's been prolonged.
Okay, well, thank you so much.
Yes, ma'am. Thanks for calling.
Thanks. And do you want to remind folks what your office number is in case they'd like to consult with you?
Sure. It's 318-683-0411.
All right. Thank you. And you can always call us. We're going to be taking calls for the next 10 minutes or so. That's 318-219-4569. So we were talking about incontinence, how childbirth impacts it, and you know, you mentioned there are some medications, but there's also a lot of non-pharmaceutical ways to treat this.
Yes.
Earlier we were just talking about pelvic floor physical therapy.
Yes.
Tell us about that.
Yeah, sure. So certainly most physicians and most women who have incontinence will know and will learn from their physicians to do exercises on their own, right? Kegel exercises, where they contract the pelvic musculature to try to strengthen those muscles to help with continence. Most of us probably do a really bad job of actually contracting the correct muscles. There is a subspecialty of physical therapists, of which Shreveport really is lucky to have a few of in town, who specialize in helping patients strengthen their pelvic floor, basically. And I like to think of a woman's pelvis almost like a bowl, and lining that bowl, there are multiple muscle groups throughout that all contribute to maintaining continence and maintaining a healthy pelvic floor. When that musculature is disrupted for whatever reason, people can have significant issues with their bladder. And so pelvic floor physical therapists do pelvic exams and identify problems in women's pelvic floor and then target rehab therapy to help them rebuild that musculature. And so that is a part of the therapy for incontinence and for overactive bladder, for dysfunctional voiding that may predispose to urinary tract infection. And so certainly this is a multidisciplinary approach. Yeah.
It's, you know, you mentioned it's a contained system, but there are so many ways to go about it.
Right, absolutely.
And you mentioned some medications. What are the medications you would use to treat incontinence?
Sure, so there's a couple of different classes. Some of our oldest medications, patients may have heard of ditropan or oxybutynin. We've progressed and there are newer classes of medications that we can use. There are a lot of them. There are a lot of them. The newest medication is the only one in its class. It's called Mirbetriq. A lot of the older medications have bad side effects, so they can cause dry mouth and constipation, and nobody has time for that. So as we've progressed to newer medications, they have seen a decline in some of those side effects. So that's been nice to have a therapy to offer. But there are a host. I mean, I would argue there probably are on the upwards of 15 or 16 bladder medications that different people are on, and they work differently for different people. Obviously, not everyone experiences the bad side effects from that.
Right, and I wanted to pose to you the same question about incontinence that I did for urinary tract infections. What is the greatest misconception?
Yeah, that's a tough one. You know, again, I think it's the blame and people thinking that they've done something. I'll see women who come in and they say, well, I finally am coming to see you for incontinence, but the reason I'm incontinent is because I'm overweight. And I'm looking at a woman who maybe, if you're looking at ideal weight, is 15 pounds overweight. Well, that's not solely responsible for your bladder leakage. And so I encourage people to seek help if they have those problems and to realize that we're here to help you. We're not going to blame you and say that you've done something to deserve this or you've done something that makes you prone to having the problem. A lot of times it's anatomy issues or genetics or nerve issues that it didn't matter if you were bone thin or if you were very overweight, you would still experience the same problems.
All right, and we've got another caller now. Lauren, thank you for calling. What is your question?
Yeah, hi. I have been diagnosed with a bladder prolapse through the vaginal wall.
Yes.
And scheduled for surgery, but I still have some questions, and I really can't talk to the doctor straight ahead. So Anyway, I'm wondering what's the rate of bladder damage after the vaginal hysterectomy? Do you know anything about that?
The rate after a vaginal hysterectomy, the rate of damage to the bladder?
Yeah.
It's
like, I heard you mention the, some possibility of damage on that.
Right. Yeah, any pelvic surgery has a small risk. It's actually much lower than you would think, especially given the close proximity of the bladder to the uterus and the vaginal walls. Usually, if there is damage to the bladder, it's because the patient had a disease state where they had significant scarring of their bladder to their uterus. And most of the time, their gynecologist has talked with them about the risks of that, and they know that ahead of time, that they may be at increased risk compared to the general public because of the nature of the reason that they're requiring the hysterectomy to begin with. Does that make sense? I may have not been clear about that.
Yeah. Well, how does the bladder get scarred then? Before the surgery or after?
Usually before, a combination of both, I guess. Sometimes if women have had multiple cesarean sections, or if they had other pelvic surgery for ovarian issues or colorectal issues, they can form a little bit of scar tissue down in the pelvis in that area. Certainly after any surgical procedure, women can have a little, or men, can have a little bit of scarring related to having a hysterectomy, meaning that that tissue may be a little scarred in there. But for the majority of women, that doesn't translate to problems post-operatively. So our bodies really have a remarkable ability to heal. And most of the time we don't see long-term problems from that.
Okay, good. And one last thing, like I said, the bladder's already prolapsed through the vagina wall.
Right.
So, and I've had two doctors, one in the emergency room, told me I could go back to work, and I work construction.
Oh gosh, yes.
So, yeah, so I'm kind of wondering, is it going to be okay to go back to work with it already out?
Yes.
Or...
So fortunately, while it certainly can be uncomfortable and it can cause bladder symptoms, prolapse of the bladder down through the vaginal wall in most cases is not dangerous. And so I fully understand why that's alarming and why patients are concerned about that. Yeah, I absolutely understand that. And I also understand why a lot of women proceed to have their prolapse repaired. Women like yourself who may do heavy lifting in their job or something along those lines are at increased risk from experiencing prolapse of the bladder. And certainly surgical management of that is a good way to correct prolapse. Go ahead, I'm sorry.
Oh, no, I was just saying, okay. So you were going to say something else?
Oh, I was just going to say that in terms of work restrictions and what I allow patients to do, we sort of base it one-on-one based on what their expectations are, the hours that they're doing it, the amount of weight that they're lifting. Pre-operatively, it may be uncomfortable for you, obviously, but in terms of causing a long-term damage or something that is causes permanent changes or is certainly life-threatening, I would say that would be very low risk to work with bladder prolapse.
Okay, good, because I didn't know if it was going to fall all the way out or what.
Yeah, it gets pretty far, but it is anchored. It cannot fall all the way out. Yes, that's I get that question a lot, actually. That's probably the most common question I get about bladder prolapse.
Okay, good. Well, that's a big relief, and I appreciate it.
Yes, ma'am. Thank you.
All right, thank you, and we wish her a speedy recovery. Hope that surgery goes well.
That's right.
We've got a little less than 2 minutes left, and I did want to get back to something I just remembered that I forgot to ask you.
Okay.
How is Botox used to treat incontinence? We think about it in a cosmetic sense usually.
Of course. So some people who experience incontinence, the reason that they experience it is because of really spastic bladder muscles. The bladder, I like to think of it as being made up in 3 separate layers. There's an inner waterproof layer to the bladder. There is a muscle layer of the bladder, and then there's sort of this fatty tissue that kind of protects our bladder. Botox is used. We look in with a very small scope, and we deploy a little hair-sized needle through that scope. We've already soaked the patient's bladder with numbing medicine, and we use that needle to inject very tiny amounts of Botox into the bladder muscle. And what it does is it actually paralyzes the muscles surrounding that small area where we've injected, so that overall, instead of the bladder being very spastic, it dulls down the amount of the bladder spasms, essentially.
That is really interesting. Yeah. All right, well, we've got about 30 seconds left. I want to give you one more chance to let people out there know how they can get in touch with you.
Sure, yes. Our phone number is area code 318-683-0411. And everyone in my group specializes in some capacity in bladder leakage and infections, so we're certainly happy to help.
All right, Dr. Ashley Baker with Regional Urology. She has plenty of colleagues also there who will help you out, and we thank her for sitting in the hot seat with us today. That is all the time we have. Have a great afternoon.
Thank you.